Excellent. Turn the recorder on. Okay, so let me just start over for about 30 seconds as I started the recorder here. Okay, great. I think it's going. Yeah, great. Okay, fantastic. Okay, so a little bit of normal anatomy is that, I started asking questions of why is the thing straight and why is it curved? And how does this thing work together as a unit? And instead of looking at it just at man's eye, which is, oh, I see this wedge, I see this atlas is rotated 1 degree, oh, this neck is bent 4 degrees, and what is, okay, which is really what the medical model does. It says, oh, you have this disease, and they observe something, and they give it a name. Well, it's the same thing we do in chiropractic. And today, I look at the anatomy, and I say, we have a nice frontal plane here, and that frontal plane, if you look at the musculature, is 4 triangles, and this is the structural support system of the body. This is where it's supposed to be nice and strong. All right, and that's what that frontal plane does. And the sagittal plane goes ahead and gives us the curves. It gives us this bounce. So we have this stable bouncing system that actually does what? Okay, it modulates as it moves, and it interacts because it has a nervous system. So it's kind of like this spring building with a head that is able to modulate on top of itself so that we have balance and move, okay? And we're going to talk about tonight in a very fast pace of a global view of how that thing operates and how it gets damaged and how the body goes ahead and tries to restore itself, and then trying to have a conversation on how to help the body get back to this nice stable space that the current model is what? In biostructure, it's tensegrity. So with QSM3, we're looking at a global model, a current model, and we're looking at the anatomy and the physiology and the nervous system and trying to create a blend of all of that so that we have an animate and inanimate system, because that's what we have. And if you look at chiropractic today, it really has, for about 99% of it, is basically about, just the nuts and bolts of the system. Okay, and what is the other side of the system? There's a life force in there. We talk about that we have a nervous system and then we get to help it, okay? But we don't have a system in chiropractic that actually communicates those two together. And that's really where medicine goes wrong, is because they try to treat a body from a physical way, like a car, okay, take this pill for this thing, but they forget there's a life force in it. Well, chiropractic says there's a life force, but we don't have a method and application that actually gets to blend that together. And that's what QSM3 has done. And I had no intention of that happening, except that that's what happened. So it's kind of like I lived on this side of an upper cervical world, which is the highest in the nuts and bolts and measuring the physicality, and it has really no concept of the life force. And then you have other techniques that have high life force, high energy discussions, and they don't really have any empirical data and understanding of how the body works from a physical way. Okay, and that's what this does, is it tries to bring this together, and that's where it goes. And that is because we are a technique that actually brings life into the human body. I can look at a full spine, and I can see the traumas in it and the neurological responses, like most of you can on this call now, because of this, and see how the body has been broken down over time, look at what things are not in the right places biomechanically, and a system that tries to restore them. So we're going to review that tonight, and that all starts with this baby right here, okay? And what this is a beautiful model of the 6 structures of the human body. And within this model there is the concept that there is some new, here we go. Okay. So we have these 3 in the beginning here that tell us, we call those structure. We call these neurology. And these 2 guys are interesting, okay, because this one is the low hip, right here, the first one. The second one is the fixed point, which is the spine, the way it tilts. This is the right hip is down, the first one. The second one is the spine is tilting to the right. And it says on the other side of this It says, I'll get to this third letter in just a moment. It says, hey, here's a shoulder, here's a neck, and here's a head. And these guys are the structure of the body, and this is kind of like the neurology of the body. And that's not really true because they're all structural pieces. But what happens is when the lower part gets knocked off, the top moves above it. Okay, so if you get knocked off to the right, like this says this is, the neurology should turn you back. Okay, and there's basically just two platforms that do that. You know, your pelvis goes off one way and the shoulder platform turns back the other way. All right, and we look at this postural listing with a lot of depth that we're going to talk about tonight. I'm trying to erase some of this, and we're going to talk about things that I started bringing up in Atlanta so that we can start having full conversations. And it starts very simply with understanding some of these letters here. So let's just talk about the postural listing for a moment. I'm not going to use the pointer and stuff like this because this class is where most of the people on you know exactly what I'm talking about. But you have a postural listing, and there are normals to it. There are normals in a sense that the structures, those blue letters that are, should be the same on one side. So the low hip, the spine, and the weight should all be on one side. And then on the other side, the shoulder, neck, and head should oppose. So when those things are together in one unit, like RRR, we call that's an integrated structure. On the other side, when there's an LLL, that's a integrated neurology, meaning those structures are in their proper alignment. Okay, so as the hip goes off, the spine goes off, the weight goes off, and then the shoulders, neck, and head should oppose. Now, that doesn't happen all the time because there's multiple traumas. And the shoulder could be not on the left in here, and it could be on the right, and that's a problem for us to recognize. Well, the shoulder could be on the left, but the neck could be on the right and the head. So there's all these things get all scrambled up, okay, from all this kind of trauma. And guess what happens? We look at this thing in real time where they are today. And that picture is a picture of where they are today. It's not where they are tomorrow. It's not where they are forever, okay? It's not like this is it, and it's a soup mix, and it will take care of them. So the concepts that we talk about in QSM3 is not do this, do this, do this, but to understand what's going on so you can make better decisions, so you can watch the way that the body is going to unwind, and it's going to communicate with you because every single patient is different. And if you understand this postural listing, the depth of it is, I feel like times like I understand everything about it, and something else pops up for me, like recently. So it's a cool little, how many letter number thing it is, and it tells us about what the structure is doing. Is it integrated? Does it tell if the neurology is integrated? Does it say if it's balanced, where the structure is integrated and the neurology is integrated, like it is here? The blues are all the same, the reds are all the same, and they are opposing. So that's a balanced equation. And guess what happens when the weight is under 3 and the rotations are coplanar and they're under 3? We call that sustainable. And those are normals. And so we look at this thing, it's fascinating because you can say to a patient, there are basically 3 big components in this thing. And that is that this thing gets knocked off center, the 6 stories get zigzagged, and their configuration is all over the place. And at some point, it's going to fall down. Okay, so if it leans out far enough or it's got too many zigzags in it, it's like a bunch of bricks. Zigzag them and, tilt them, put a little pressure on them, and they fall down. And we can measure the ability of the human body to hold up that patient, to hold up that configuration at that weight differential. We can measure the collapse of the human body and the energy of it. And nobody else can do that. So when somebody gets up to a 10 of twist or a counter rotation of any magnitude except 1, 2, or something like that, there's big trouble for the people. It is saying that whatever that configuration is and whatever that gravitational tilt is, that weight differential, that person is collapsing down. And that's a huge measure because you can have somebody that has a balanced equation that has only a pound off and they've got 15 millimeters of twist. And there's something that you need to understand about that. Okay? What about the person that has a 28-pound tilt, and they don't have any twist, okay? We need to be able to understand those concepts, okay? So the depth of what is going on here is what we're going to discuss a little bit tonight, okay? And it starts with that we have trauma, okay? And we don't see integrated equations. We don't see balanced equations. We don't see sustainable postural listings, okay? We see problems like in this one, okay, right here. In this misalignment, I've got a new setup here, so I got to find my toys to draw with. Here we go. So, if you look at this right here, if the hip and the spine are supposed to be together and the weight of those three guys is supposed to be together, that guy ain't working there. Okay, so we start looking at where the dysfunctions are, where the trauma is, where the body is biomechanically incorrect. All right, and at the end of the day, I look at the algorithm, I look at the dysfunctions, okay, and I put that together and I watch what I do in my releases in different areas, different areas as far as C7 and C5 and C5 to C1 to release different things based on this information here. Okay, and that's where I want to be able to take you, is to be able to have that same understanding. So being at this review and being at the class and being at the in certification is basically saying to your patients that you want to do the best that you can do. All right, so we look at this guy and we see, wow, there is a dysfunction here. All right, so somewhere the body has to be compensating for this thing, okay? And where is it doing that, okay? So just feel this misalignment for just a minute. You're sitting in front of your phone, your computer, your iPad, and just lean that hip down and tilt or stand up, and you could feel this. How does this thing happen like this, okay? This thing has a right low hip, a right shoulder that's low, and a right neck, okay, and a spine that's on the left-hand side. It's 22 pounds off the center, but the whole midsection is pushing back to the left, the spine. So you should be able to put yourself into that position physically and energetically, meaning when you're standing there and you're seeing that patient, you should be able to put yourself into that position. You should be able to see that listing completely and see what it's doing and get to a place where you see how you're going to lift it up and out of there. And you can't do that if you just look at it as a bunch of numbers. You go, wow, look at that 20. Yeah, look at that 20. Okay? But after you look at that 20 and you go, wow, look at that 20, what you got to do is, hey, guess what? They're here for me to help them to release this thing. And I need to have those numbers change. You got to be able to do that by not being just on the side of the number. Okay? You remember, there is a physicality and an energetic component here. There is an animation and an inanimation in the human body. It's not just about the numbers. Feel that stress. Feel where it's energetically unsound, okay? And see and feel how you're going to lift it up and release it up and out of there. Okay, use all your senses in this. Any questions?
They like when you show them what they look like.
Yeah, well, I mean, I have an X-ray in my office, and I can show them that. I show them on the posture IQ, okay, and I show them where they're standing, okay. So it's simple, and I stand in front of the people and in back of people on the posture IQ, and you can really see the flow of what's going on. There is no way I would just look at a posture listing and just take it, okay. I have to get myself into seeing this and feeling it. Okay, it's a much more, you have to learn the rules, you have to learn the biomechanics, and then you have to see it and feel it when you're at the end of the day. Okay, but you got to learn the rules first. Okay, so we have these things called dysfunctions, and those are really biomechanic abnormals. Okay, it's like it's like your head is moving in one direction. Tilt your head over. Okay, and you see how your neck comes with it? Yeah, because it's supposed to, right? Okay, well, what happens if it didn't come with it? Why don't you keep your head on the left and tilt your head to the right the same way? You go, that doesn't feel good. So there's normal biomechanics, okay? And you can recognize those biomechanics, and that is that low hip, that fixed point, that spine, and the weight should be on one side, and they should be together, and the shoulders, neck, and head should be opposing, okay? And when they're not, we have to look into this so that we can see how we can help people and release them as well as possible, okay? So I like to look at things called an indicator. So we have these things that break down, but the indicator is the thing that the neurology is doing above that because, guys, we're not a building. We're a building with a nervous system, okay? So the body has an ability to try to turn itself upright. It does that through that righting reflex, all right? So that's why we have that proprioceptive bed over C0, C1. It sits over L5, S1, is because they're supposed to efface each other. So as that hip drops down off to the right and the spine goes to the right, the shoulder platform, the neck and head, that shoulder should carry the neck and head over. And if it doesn't, guess what happens? Because there's multiple traumas, we have dysfunctions, we have indicators above. And we're going to look at tonight at some of those things, okay? So that we could try to make those correlations. Why do we want to make those correlations? Because we want to see the way the body is out of place so that we can understand a way that when we do something and it responds, is that a good thing or is it a non-productive thing? Okay? Not because we're going to push it to a place, okay? Because I did that for about 15 years. I tried to push the body into a place. It doesn't work well. It's non-consistent, okay? So, and the reason for that is because these things are not just linear, like a 2x4, and you're just going to push it, or a car, you're just going to push it down the street, and you're going to turn it to the left, and you're going to get it right where you're supposed to do that. The body is not that, okay? The body has been damaged. It has a nervous system. It has short tension in it now because it hasn't been used in certain areas. It has good tension trying to hold it up. It has bad tension that's falling over. It's got damage, and it's got an inherent energy capacity. And it's our purpose as a QSM3 chiropractor is to try to take that person and try to get that, all the stuff that I just spoke about, try to get that person to a better place in a tensegrel volume. Okay? So understanding the postural listing and the dysfunctions and the indicator is the first step. Understanding what balance, what integrated, what sustainable is, when it's non-coplanar, what the rotations mean energetically, that this thing is collapsing, seeing the configuration, seeing what's not functioning properly is all the name of the game. And I do that on every patient, okay? And the purpose is to do one thing, okay, first, and that is to release this thing. Okay, remember, it's a spring. It's got some springability. It was made to be a spring. That's what tensegrity is. All right, tensegrity is the human body that is expanding outward. The fascia has we have a pressure inside us, right? All right, and that pressure is pushing out. Push your stomach in, it pushes out. Okay, so there's pressure inside it. And that pressure, okay, that system gets damaged like a balloon. So you push down on a balloon that has weaknesses in it or holes in it, guess what happens? It starts kinking and starts going flat. And we see that's what our elderly look like. They're kinked and flat. Okay? So there's a lot of in between when somebody comes in from birth all the way to that place. And that's what I do, is I try to figure out how to open them up. My job is not to push them. My job is to release them, open them so the nervous system and innate intelligence could do what it's supposed to do. And it's cool because when I do things, and I think that that's what the body needs, and I feel it releasing, and I go ahead and I look on the posture IQ, and I see the whole thing fell over. And I learn stuff from that. I see that when it opens up, which means the rotations reduce. Since rotation is compression, I mean, think about that. I tell my patients, I said, if your house was tilting, if your house was bending in little different directions, or the house was falling down, which would be more problematic? And obviously, it's the house falling down. Okay, so it's job one, is we need to lift these things out, try to find a way to help the body pop up and out as much as possible and reduce those rotations. Okay, so that way, the body can go ahead and start putting itself back together. And that's what I try to support as a chiropractor and a friend and kind of the kindred spirit to that patient's innate intelligence. I try to see what it wants, and when I get them up on the posture IQ, which is my empirical data, my hands are my magic energy. I feel resistance and tension with them, and I open people up. I feel that release, okay? And that's what I share at the conferences. Okay, here is I want to share the the biomechanics so that we can understand how to do this better, and that is to open them better. Okay? And what we want to do is find the best release to give us the most stability. Okay? Because there's lots of releases that change things. That's all we do in chiropractic. That's all we do in healthcare. We have people that work on a foot in reflexology, and they go, oh, my sciatic's gone. Okay? My liver's better. Okay? Because the body is amazing. Okay? My purpose is to try to support it back to kind of the manufacturer's credentials. Okay, so the misalignment that walks into your office is part damaged. So it's not a spring anymore. Okay, so there are people that walk in that have still 90% spring capacity. So when you go ahead and you release them, boom, they pop right up and they're happy as can be, and you look wonderful. And then there's people that have 30 pounds off a center, and you go ahead and you release them on the left, and then you go release them on the right, and it ain't moving. Okay? And that's not your deal. That's not your fault. Okay? That's their problem, okay, which we're going to try to figure out and help them with. Okay? Because I have those too. Of course I have them. I always have 2 or 3 problems. I've had 2 or 3 problems since the day I started. I just have 2 or 3 different problems now. And they're not problems now. They're just, I found that if you stay with things, they get better. All right?
Question.
Yeah, 1 second. So understanding this concept that we are a spring, okay, that has been damaged, and that we just don't go push button, and I'm going to push it here, and guess what it's going to do there? Because every single patient is different, that has different damage, and they have a different energetic capacity. Okay, and it's a math problem. I posted that on Facebook the other day. Okay. All right. So who was that, Brad?
Yes. Is the weakness of the spring indicated by the amount of the weight?
No.
Okay.
No. No, the weakness of the spring is not determined until you start releasing it. Okay, because the spring could just be when somebody's in a bed and walks in the door, they have damage, they have things that are just jammed up. Just take your finger and bend it over and then let it go. Well, you didn't break anything, and it popped right up the center. So there's lots of misalignments that have a blend of damage and stuff that's just stuck. And once you get stuff moving, you could see behaviors, and once you see patterns and behaviors, then you could start seeing how that spring behaves and how healthy it is. And all this stuff is over time. I got patients that I have in my office for 2 months. 2 people today. 2 months in my office. I said, I think I really know how to. I think I know how to get this thing now. I said that to 2 people today. I made some shifts in what I was doing, and I saw something a little bit differently today, or the past few days, and I made some shifts, and I saw some on 2 people. I saw something clear. It's been 8 weeks, Brad. Frickin' A.
Okay.
Look, and I'll tell you this, okay? And I don't know who's on here or not, but and I don't want to say I challenge anybody, but realistically, I would challenge anybody to show me that they could fix anybody in a visit at any level one time on the planet. I give them 100 people. It ain't gonna happen. How do I know? Because I'm not doing that, even close to that. That's not even that never doesn't happen. We're not here to do that. People have been damaged. That replacement thing is a mechanistic mentality. We have what we have, and we just need to help people, and they've been damaged, and that's great. Okay, I mean, the dentist doesn't make an excuse when he tells you have to brush your teeth forever. But this is the name of the game. Some people need some push, and some people don't. Okay, because the body is a spring. And springs behave differently. If you wanted to move a spring, you wouldn't push it. Okay? If you wanted to move a building, you push it. If you wanted to move a spring, you release it. Okay? If the spring doesn't have any potential energy, which we're going to talk about, you're going to have to bend it so that it can create potential energy. How do you want to bend it? You want to bend it so that When you let go of it, it goes in the direction that you want it to go in. Yes? Yeah. Okay, so we got to learn how to spring a little bit. Okay, so the reason we're going to do this is because the body has two springs. Okay? It has a spring, and I call it spring one, which is the pelvis to the shoulders. Okay, and that is the major spring. It's like 80%. Why is that the major spring? Is that when the pelvis goes off to one side, the shoulders should bend back the other way. We know that relationship. Okay, and you'll see that. We're going to see that as on some film in just a moment. We're going to see the truth of that. Okay, so when somebody is damaged off to, say, like in the right frontal plane, say here's right, say it is the right side. Okay, and this is somebody's pelvis. Okay, this shoulder should not be doing that. Okay, it should be bending back the other direction. Okay, more like this. Okay, more like that, kind of thing. Okay, that neurology is not normal, by the way, but that neurology is functioning. Okay, working properly. Okay, so we have these springs, and there's two types of springs. Okay, one where the top and the bottom are together, coplanar, and one where they're not together. Okay, and why is this important? Because when you have a shoulder that's on the right and a pelvis that are on the right, that is called a coplanar spring. Okay, and you have to release that a certain way. Well, it's got no power like that. Okay, so what do you have to do to this to get this moving? If I wanted it to get it to center, what would anybody in this room do? They would push this down here and let go, and it would fly back up this way. Yes? That's what you would do. Any questions on that?
It would hopefully fly back that way.
Hopefully, that's the idea.
And
Okay, so if I had, we're going to go through examples of these. I'm giving you concepts. I told you in the beginning, I'm going to go through examples. So we learned this at the conference. That's why this is hopefully a review for some. Okay, so when I have a shoulder and a pelvis that are not coplanar or are non-coplanar, okay, where I have, say, a left. This is about the driest thing that I do, but it's a little bit of math because the body's got some physicality. You got to learn some of the physicality, not just the innate intelligence to do it all. Because if innate intelligence was going to do it all, guess what? It would have done it already, guys. Okay, that's a news flash. Okay, so we got to figure out some of the nuts and bolts here. And when there's damage and we lose the spring, we lose some of the life force, and we got to help it in the physical realm. Okay, so when we got one of these guys, you don't have to do anything for it. You just got to let it go. Okay, and the idea, and that's really what we do, is we look at the two springs, and the two springs are right here. Okay, so we have spring one, which is the pelvis to the shoulder, and spring two is the shoulder to the head. And what this really is saying, that when, in this case, if this was the right, I'm looking at somebody's back, somebody gets knocked off the center, the shoulder should turn back and bring the head and the neck up with it. If it can't, guess what has to happen? This spring needs to take over and help out neck and head. And what do you think it does when what do you think happens when the shoulder doesn't do what it needs to do? Go ahead and lean your body over to the right and leave your shoulder there and just bend your head and neck back. Feel that. It doesn't feel good. Okay? So if you could look at a postural listing and see this and see that shoulder is not functioning, now you have an understanding why that patient has trigeminal neuralgia. Now you have an understanding of how that shoulder has to change, not that you have to push it, not that you have to release it, but you have to find the algorithm and the release sequence that's going to head and pop that thing up as well as possible to take that stress off that neck and head. Okay? Not just there's a bone out of place and I'm going to push this thing. There's 206 bones with a nervous system that has been damaged, that has got dysfunctions all over the place. And the faster we start understanding posture, which is our business, we will start actually be get noticed. Okay, again. So, that being said, here is an example. All right, so what I do is I look, this is really simple. Okay, is I look at the relationship of let me clean that up. All right, and then we're going to go through this stuff with some examples in just a moment. But here, what is the relationship? That says right for the low hip, and what is the relationship for the shoulder? It says it's left. So I have a spring that is right down here, okay, and it's bending back to the left. That is a non-coplanar spring, okay, left, right. So how would you release that? I want to get it to go to center. I want to integrate this spine on top of this pelvis, okay? It's a foundation theory, okay? You fix the bottom, the top stuff doesn't have to compensate as much. You fix the bottom, the top, so forth and so on, okay? So we want to build this thing bottom up, all right? So with this, my first release would be left. Any questions? Okay. The biospring for the second spring up here is a relationship of the shoulder, and the head. Okay, and you just look at the top to the bottom. Okay, the top to the bottom. This is the top here. This is the bottom for this. Okay, so I have a right with a left on top of it, and now I have a left shoulder with a right neck. So I have a left shoulder, okay, with a right neck. Trying to write this here. Boom. Again, it's non-coplanar. So I'm going to release it on the right side, and it's going to go flying this way. So that's my release, is a left-right. That always feels brutal for me to go through this. Does it feel brutal? Okay. So that's the math of it. Okay, so let me give you the news flash. The news flash is that if this was a 100% healthy or somewhat healthy individual, and those springs were working great, guess what? I would release this thing left, right, and it would all go to center, and I'd probably never have to touch them again. But that's not the case. So sometimes, okay, because this thing has been damaged, the algorithm isn't going to help you. So what I do is I always release the first one first, okay? Look, I have a practice that I can check people in between. Why? Because it's important for me. Okay, it's important for me. And so I've set it up that way. Okay, so I see people in 10-minute visits, and I can adjust this person on the left, and I can watch what this thing does. Okay? Because it's not 100% healthy, it may only need me to adjust it on the left today. Okay? And I want to know that. All right. All right. So that's just opening up a little can of worms right there, is that the algorithm is great for the perfect human being, but nobody's perfect. So sometimes we're not going to do some of the algorithm because we're going to work on areas that allow things to happen first. And sometimes the algorithm isn't going to work, and I'm going to have to add to it because the body is not a spring and it needs help with a building. Okay? So let's go through some of that and we'll see what we're doing. Okay. So let's just have a little bit of concept of this is another concept. So what I've spoken about so forth in concept is I've talked a little bit about the anatomy, the tensegrity. I've talked to you about a global look. There's a life force. I've talked to you about the postural listing and about the different ways that we look at the postural listing: structure, neurology, sustainability, balance, integration, energetically, collapsing, integration, dysfunctions, head tilts, so forth and so on. We're going to go through practicing them, okay? We see that the body is a nervous system, so we have these dysfunctions that are where the body has been biomechanically knocked off center. That's what a dysfunction is, and that's something down below, and then something above is trying to compensate. That's why we have a nervous system. And then I said, okay, what's the purpose of this? Now that we kind of are getting an idea of how this postural listing is working, saying, okay, how does this thing even from the manufacturer, the physiology of it even work when it's damaged? And that is this, is that when it goes off center to the right, the top of it swings back, okay? And it's a spring system that does that. It's called tensegrity. So tensegrity is not, it's an expansion. It's not a compression. So we can't look at this as like a building, okay? You can't, that's why you can't push these things. And how do I know that? from this very fact, if you're a chiropractor and you measure people on scales, you have adjusted somebody on the right side with 10 pounds on the right side. So you have them right side up and you push them right to left. And when you get them up, they're not right 10, they're right 30. So buildings don't push back at you. They don't bounce back because they don't have that capability. Okay, go push a piece of concrete. It doesn't jump back at you. It either doesn't move or it goes forward in the direction that you push it. It's a physical law. Okay, but springs don't act that way. Springs, you could push them, and when you take your hand off, it could bounce back and smack you in the face. So by understanding that, when I start seeing that happening, I said, wait a second here. This is not working right. And it's with that, it's then that I realized that I stopped saying, hey, we're just 10 Seagull. I saw us being 10 Seagull. Okay? And that was cool for me. So I was able to create a global model and now have an application with a global release system, which is a spring system. I left the bone, I'm pushing a bone. Okay, so I was talking to integrity, but my release system and the way that I move the body was by pushing it. Okay, and that's not what I do anymore. I release the body. Okay, I feel for short tension and undo it and let it expand in against my piezoform. Okay. So then what I talked about is there's basically two types of springs. Springs that are coplanar and springs that are not coplanar. And you have to release them differently. The coplanar ones, you got to push them down to pop them up. So if you had somebody with a postural listing of all rights, I used to look at that and I go, man, I have to push that up. I want to say that again. Okay? Meaning if it's a all rights, I've got a right low hip, a right spine, a right weight, a right shoulder, right neck, right head. Who in their right mind would push that thing down? Get them left side up and push them down. Me, I do it every day. Why? Because it's a spring. And if that spring is healthy and I can release it, it will pop up the center and it'll go from right 30 to right 5 to right 8 to left 2. Maybe it'll go to right 16 because that spring's telling me, hey, Russ, I can't do the whole thing, but I'm still getting it pretty close to the way. So what do you think I do? Then I flip it over and I help it up like a building. So it needs part spring, part building. Okay? And so what I do in my office is I release it, and then I teach people how to stretch it, which I have to understand what's short. Then I teach people how to strengthen it, okay? Because if you have something that's damaged, then guess what? You got to have something to pick up the slack. All right? So you have to understand what has to be stronger. Okay? And I'm going to have a little bit of concept with that. That's what I'm going to shift into now. Okay? And understanding cause and effect. Okay? When a front end is out of alignment, guess what happens? The tire wears down incorrectly. Cause effect. Okay, so I'm going to have a little bit of a concept conversation for some of my people that have been around a bit for a moment on this. Okay, so let's look at this first one here, and that is this one here. Okay, got a right 12, P5, P5, LLL. All right, and what this is saying to me is that this pelvis has been damaged off into the right frontal plane. Okay. This side is short. It's dropping down. Is that fair? Can everybody see that? From the TFL down. What I am talking about, what is short right now, is their primary short. What's primary short? Not that it's short up here in the compensation, okay? Where it's primarily short, meaning where it happened first, okay? And because the body has a nervous system, I have to look at the bottom to see the first problem. So because this person does not have a balanced pelvis, okay, I look at the pelvis, all right? The pelvis is misaligned, all right? I am looking at the lower extremity now too, okay? And I do have a good understanding of it, but we're not going to talk about that today. The pelvis right now is the lowest point. And this person has a right low hip. So with a right low hip, this TFL on this side is shortening down. all right? And this person is shifting out 12 pounds to the right. So if the right side is short, the left side is weak because it is unable to hold this person upright. Okay? Is it doing a decent job? It's doing something. You could see the effect of this trying to react to this. This is a big concept because this side right here and this shoulder is good tension. This left shoulder is what's holding this person up completely. So when this person comes in and say, Dr. Friedman, I have left shoulder pain, I don't go, I'm going to dig that out of there. Why? Because if I dig them out of there, they end up over here like this person here. And when I let this go here, guess what happens? I just let this left shoulder tension go. That's holding up this right hip like this in this diagonal. That's where it anchors, all the way up there and all the way over here. Everything over here is trying to hold this up from this guy falling over that way. Okay? And when I go ahead and I release this point here, okay, guess what happened? That guy falls over and I just did this. So this person here, when they walk in your door, is in much bigger trouble, this second one, than this guy here. This guy is in much bigger trouble because his shoulder and his normal neurology is failing. Okay? So I don't look at this as, and this is the way I used to teach it, and we're going to shift out of this. I used to teach it as the shoulder was damaged. Now I see it as the shoulder is failing. Okay? And when the shoulder fails, guess what else has to pick that up? The neck, the head, and guess what else fails? That's where this fails down here. And that's the lower extremity. And we're going to tie this all together in a whole three-dimensional wave at the next conference. But we got to be able to see these components. Okay, so let me erase all this.
I have a question.
Yeah, 1 second. Let me erase. And then I can listen to you. Yeah, so I do want to say one thing before Brad says something. We've talked in the past about what's weak and the power side. Just forget that concept because that is not what I'm talking about here. What I'm talking about is the muscle system that is being asked to activate because of the damage. Because this right hip has been damaged in number 1 here and in number 2, okay? This shoulder, this head, and this neck are all pulling that thing up and holding it up. Okay, no different than, universal intelligence works great. It's same, it's physics, Okay, so this is a post that's falling over. It takes a wire and it attaches it from the top to the bottom. That's when somebody goes, you know what, my back hurts, my shoulder hurts, and this kind of stuff. I've got frozen shoulder here because this side is short and they can't lift this left arm any longer because it's been locked down for so long. And this one over here is this guy. This second one here is this guy in 10 years. He can't hold on any longer. So after this fails, then the lower extremity goes. And that's when you see all the people with their knees and their hips and everything else. Okay, it's so easy to see. See the whole thing from the damage and how the body is failing through it rather than multiple traumas, which it has. But there's a point where we stop here having those traumas. We just have failure. Okay? And we can be a great advocate for our patients, not by saying, hey, your nervous system is not right and you have a subluxation and your atlas is, high 4 and an anterior 2, is to actually having a full three-dimensional conversation with them that says, hey, this is what's going on. Okay, you've had damage at the pelvis. Your primary problem started at this right pelvis. Okay, and you've been trying to compensate, and this is failing now. And this is what I'm going to do. And these are the stretches that I'm going to give you. And these are the homework that I'm going to give you so that because I understand where your muscles have to be built up to help. So I release it, okay? They strengthen and they stretch it, okay? So in my office, Allie and Sean do some functional neurology in Grafton, and they re-educate the nervous system, and they help the person understand that part of that too, and it's very effective, okay? But the chiropractic part is, the big chiropractic part is, us releasing these things, okay? So we have this postural listing, and we could see even more into the postural listing now, is we don't just see, like I said, the integrations and all this stuff, and then this collapse in the middle, is that we can actually start seeing what's failing, okay? And once you see what's failing, then you can look at the algorithm and say, hey, you know what? I see how this thing is breaking down, and I need to help that person this way. And that's what I do every day, is I see the flow of the breakdown and I see the flow of the release. I see what I do on the machine, and I see the way the body talks to me. Okay? So that's what we do. It's the freaking coolest thing on the planet. Okay, so what this picture represents, okay, it is 8:54. I am on slide 11. Great. Holy mackerel. All right, I'm going to have to cook. Okay, so this slide right here depicts that. It talks about how I give this to patients in my office, and if you were at Sunday at the conference, you would have gotten this, and we discussed how the short side and the short side and the short side, and the side that needs to get strong. So I give, stretch and strength exercises for these two pictures. Okay, this is a left low hip, and that's a right low hip, and everybody's got them, and that's where you got to start. You got to build these TFLs and these adductors, and you got to strengthen the TFLs and the adductors and stretch them. It's the lateral movers where this thing is breaking down, and most people don't work those at all. They work the hamstrings and the quads, lunges and squats and running, and all our lateral motion is just shot, and we're just collapsing off to the side and breaking down. Okay. All right, so let's go through some. Yeah.
Do you have to stretch and strengthen everybody, or is it just sometimes you just got to stretch the fascia?
No, you stretch the fascia? No, it's not enough. Stretching is not enough.
Well, I was wondering sometimes with the spring, if the muscles are overcompensating, no?
No, there's damage. I have yet to see that. To me, that's a lifetime. I've yet to see anybody's pelvis go perfectly straight.
Yeah.
Yeah. Okay, so let's just buzz through these. Guys, I got 34 slides. I'm on 12 and I'm in an hour. Wanted to be done in an hour and a half. So we're going to boogie, okay? All right, so that's like the whole groundwork. All right, so let's just do a couple of these, and off we go. All right. So I'm going to answer some of these questions. Is it integrated? Yeah, it's structurally integrated. Those are all the same. It is not neurologically integrated, okay, or functionally integrated, okay? Structure and function, okay? Is it balanced? No. It can't be balanced if it's not integrated. They both have to be integrated, and they both have to be opposing for it to be balanced. Where's the dysfunction?
Head.
No, that's not the dysfunction. That's the indicator.
Wait.
No.
Shoulder.
Oh, my God. Where's the dysfunction? Thank you. It's saying it's right. It's a test question, guys. You better get it right. Yeah, of course it is. It's got a right low hip. Look at it. I mean, of course it is the right hip. Okay? Why would you say the weight? If it's right hip, it's supposed to go 19. It's just failing further there. That hip is failing even further. That's what you just said to me. That's what the weight is doing. Look, the whole thing is failing. Okay? Why isn't the nervous system compensating over here? Because it's failing. All this is failing to the left. Everything. Let me change my color here. Go to hot yellow. Everything is failing here. Everything is going this way, right? Do you see that?
Yes.
Yeah. Okay, good. All right, so the dysfunction is the pelvis, the low hip. The indicator is the head. So as the body and everything is leaning off and the shoulder, neck, and head are not compensating correctly, The head's picking it up. Okay? Look at the damage in that pelvis at that L4. Look at that between L4, it's a little small, but L4, L3 there. I think it's L5, L4, L3. Look at that spondylo.
Squash.
It's crazy, right? Yeah. Okay. So where's the bad tension? Where's the good tension? Okay. So the bad tension is this right low hip is just collapsing down. Is there any good tension in this thing? The whole thing's basically falling over. Okay. The shoulder isn't holding it up. The neck's not holding it up. Okay. So if you set up on this person, okay, what is the release sequence for this? You got an RR, so it's an L. Okay, you got a right. You're going to push that down. So just look at that for a moment. Do you think this person that's in right failure completely, that you would want to push it down on the left?
No.
No. Okay, but I do. Why? Because I always work the algorithm. I don't just not do that. I would do that and check it, and it may collapse further. Okay, and I don't just beat the hell out of it and take every bit of tension out of it. I don't do that. I never do that on the good tension side anyway anymore. Okay, so usually on my first side up, I don't clear it all the way because otherwise I'm taking all the good tension out. Okay, so that's the last time I'm going to talk of good tension and bad tension because that's for some people that have been here for a long time. All right, let's go on to the next one. All right, is it integrated? Definitely not integrated. Okay, is this integrated? Yeah, function's integrated. Okay, so the shoulder, neck, and head are working. All right, but there's something not working down here. Is it balanced? It can't be disbalanced, obviously. What is the dysfunction? Dysfunction is that this is probably going to be a left, 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 right, right, right. So what's going on with these rights here? So the dysfunction has to be the fixed point and the weight, probably the fixed point. Okay? What's the indicator? All these guys here. Okay, I guess. Actually, I'm going to take back what I just said. I want to look at this one more time. Okay, let's go backwards. Okay. Let's start again with this. I apologize. This is an interesting case. So with this one right here, I look at the hip as the initial dysfunction. Okay? And everything else is trying to compensate in this one. Okay? So this release right here, okay, would be what? An R and an L. RL. Okay, but just look at this for a minute, okay? All right, look how the whole thing is breaking down already on the right. Okay? I mean, this is something that I talk to myself about every day. This person has a left low hip, and everything above it is trying to compensate. So there's two things that I think are important, okay? Number one, it needs, because everything is leaning on that right side, could you see why it needs to be lifted up on that right side? Could you see that? Anybody? Does it look like it's breaking down? Look at the rotations in it. P8 and A5, they're breaking down. So what you have is look at that pelvis in there, and look at that spine down below. Do you see how it's buckled? Look at that left low hip and that buckle in that L5. How it's turning it right. Okay, that needs to be released. All right, that short tension right there is on that right side, and that's where that needs to be released, and that's where the algorithm says to start. Okay, now what does the algorithm say to do after that? Release it on the left. What is that going to release? That's going to release the cause, which is the left low hip. Look at that low hip. Okay, so you release the right release will release all this stuff up here, and when you turn that person over, you'll release that left hip through here. Okay? All right, moving on. Okay, is it integrated? Yep, it's integrated. Yep, it's integrated. It's not balanced because they should be opposing? What's the dysfunction? I'm not really sure what the dysfunction is on this one. Okay? To me, structure is always wrong and neurology is always right, meaning correct. Okay? So something isn't right here because neurology is always doing everything it can do. Innate intelligence gives 100% all the time. So if I got rights over there, something's up down below. And if everything is all rights, something down below is problematic. Okay? So the interesting thing about it, so it's not balanced. And what's the dysfunction? I don't know what the dysfunction is. I'm going to say something down low, down here. Okay? Probably the hip. Okay? I mean, it's easy to go with the hip, and you can see the hip. Okay? The hip goes off, the spine follows with it. Okay? Because the pelvis is the big mover. It's the big mass of the body. All right? I mean, yeah, that has to be a fact. Okay? From a physics point of view. Foundation's always bigger. Look at them, it's lots bigger than the atlas. Pelvis is bigger than the shoulders. Much more musculature. Okay. So, with this, when I go ahead and I adjust it, this is telling me that it needs a left adjustment. Now, that doesn't mean I adjust it twice on the left. That means that it's an RR, shoulder to pelvis, pelvis to shoulder, excuse me, and then shoulder to head is RR. So that's a left release. So I would push this thing down because they're coplanar, and I would see if it would bounce up. Well, what happens if it goes to right 20? Okay, and the rotation collapses. Well, wrong call. Okay, so I got to turn them over, but that's the way I learn. That's the way I learn to see if this person's spring is working well. Okay, why is that important? Because every single patient is different. Because I could push down on this person, and they could pop up to right 1, and that rotation could clear right out, and I could do that 1 time out of 10, and every other time I have to flip them over. But if I go ahead and I adjust the person that has the healthy spring and try to push that up, the whole thing's going to collapse down also. So I stay with the algorithm, and that's how I learn how people are doing. Because when I do this, I do that to them next time, and next time, and next time. And I stay with the left, and I stay with the left, and guess what happens? Eventually, I start seeing it change. Okay, so I have a lady that comes in my office. I said this at the conference. 32 pounds on and this is her misalignment, okay? She's got 32, this is her pattern. Okay, she's got 32 pounds on the right. And when I adjusted her, she goes to 32 pounds on the right. I adjust her on the left, she's 32 pounds on the right. I adjust her on the right, she's 32 pounds on the right. Okay, her rotation has changed. She's got 1-2 rotation now. She always comes in between 25 and 32 pounds off. So I said, you know what? I'm stopped doing this. I'm just going to adjust her on the left. And I did it. She comes in once a week. And I did it for about 3 weeks and 4 weeks. And then all of a sudden she came in at right 12. Now she comes in at right 12, right 15, right 18, sometimes right 6. But she goes, I'm feeling better. Okay? So pushing down, and being patient. And how do you know that? Because when you're doing something that's not working, you do it long enough, and you just have to just do something else. Okay? And I don't mean just flip them over and do something else, but trying to understand this from a perspective of a process and trying to see how the spring is working and functioning and so forth. And when it's not functioning, to help it. And if that's not working, like in that case, then, you have to stay with a pattern of just, trying the other side. Okay, this one right here. Okay. This is a funky misalignment. Okay. I tend to, this is interesting because you could look at this misalignment here and go, okay, I got 2 lefts over here and I got 2 lefts over here. What the hell is this thing doing? Really, look at that body, man. That's my neighbor. Look at that hip.
The hip is crazy.
It's crazy. But just look at the whole thing. The whole thing is just
big twisty.
Just collapsing. Yeah. So you can look at it on the sagittal plane where everything is just all I think I'm getting some reverb here from somebody. You got to take your mute. Okay. So with this one, you try to look into them, and you could see that it's not integrated, it's not balanced. Where's the dysfunction? You know, it's got 19 pounds on the right. You think that thing is just going to fly to the left, and the weight is off? Maybe. Maybe not. Look at that big kink on the bottom. Okay, how the pelvis is off, and how this upper part is all buckling over to the right. That's where that weight's coming from, maybe. You know? Or to me, it's the legs that are just swinging out this way. Look at that pelvis. That's where that weight's coming from. See this weight of right? It's coming from because that whole lower extremity is swinging out into the right frontal plane. That's why that hip is so low. So it just doesn't drop down on the left. It swings to the right. You follow me? Can you see that? Whole thing's cantilevering over like this and this and shifting out. Anyway, so I set up on the algorithm on this, okay? And the algorithm says release it as a right. And I watch what happens. And I like releasing it right first. I could do that. I could say, man, I'd like to just pop that thing up and see how that thing flies and see if I can get this thing to kind of integrate over the pelvis like that a little bit better. I can make up something, but I stay with the algorithm, okay? And I watch how it behaves. And the goal is to watch these inner numbers change, and that is that opening and that rotation. Okay. Now let's move on to something else. We'll get back to that in a minute. Okay, so I have a tensegrel structure that's been damaged. I have a postural listing. It's got dysfunctions, and I know we're going through things quickly tonight, but it's supposed to be just a review for those people that need a review. And I look into the posture, and you could see some of the dysfunctions, and you have a release. And I watch people in between the release. So when I have somebody that's an RL or an LL, after I do whatever I do first, I go check them. 95% of the time, I get somebody up and I look at them, okay? And I see what happens. That is the reality of everything, okay? And we're going to go through those posts in just a moment of what I do, okay? So before I do anything, and I just have sat there, I've looked at them on the Posture IQ and the grid and in front of them and back of them, and I like just looking at people and seeing how it's breaking down and the flow of it and so forth and so on. And sometimes I'll take a picture of it and I'll go and take an x-ray to just make sure that pelvis is on the side that was originally. Once I do all that, I forget about all of it. Okay, once I know the side that I need to lay him down. Because all that conversation of what I think is going on, what's the dysfunction, and all this stuff is just a conversation Russell has with Russell. Okay, because I'm just trying to look at this in a cool way and saying, what's going on here? Why? Because I don't like looking at people as numbers. I like seeing human beings, see how it's breaking down, and feel it and taste it and live it. Okay, that's what's made me good at what I do, because I try to approach it from all different avenues that way. Okay, but once I'm done there and I lay them down, I shift out of the mind mode and I go into my soul mode. Okay, it's no longer my brain's thinking about what's happened. My piezoform is going to find out what it can do with that short tension. And if the algorithm says, Ross, start them right side up, I start them right side up. Okay, so let's talk about patient placement. You have a balloon, you have a tire, it's lost air. You want to fill it up. As you go through the process of filling that person up, you need to keep stretching the balloon. How do we do that? Okay, because you need to create tension. So patient placement it's simple. It's made to move somebody towards tensegrity. Okay, towards that position of tensegrity. And it's like blowing up a balloon, and that tension has to change. So patient placement has to change. Okay? So patient placement changes in a number of different ways. Okay? Patient placement changes by changing the legs. Okay? I change them from relaxed to stretched. Okay? This is a stretched balloon. That's a non-stretched balloon. Okay? I do that by tipping the head back and tipping it forward. Tip your head back, you'll feel it stretch the front. Tip it down, you feel it stretch in the back. Okay? And if you want to stretch something, okay, and you live in a tensegrel model, you have to go beyond what is not stretched, okay? So wherever it is you have to take it to a stretch position. I have to tell you this, and you need to hear this, because if you keep poking at people, you're not changing their tensegrel volume, all right? You have to be able to stretch a rubber band. If you want to stretch your arm, you don't just raise it up and just kind of raise it halfway. You have to take it to the limit. So you have to learn how to find the limit with people, okay? And you have to, at the end, take people to full three-dimensional motion, because that's where the magic is. And that starts with getting people in tension, not locked up. Actually, you just have to have the opposite. You have to have people relaxed and moving, usually, okay? There's one exception to that. We'll get to it in just a moment. So there is a temporal support. Because we need to have motion, okay, I like a little expansion. And what that means is the space that I create between the neck or the shoulder and where I brace the head, the bigger the distance, okay, the more motion. It's pretty simple, okay? If I bring the head as high up as I can, I limit motion, okay? If you have really flexible people, you need to bring them up higher, okay? Because you can't knock somebody off the table by driving them, 6 inches out through the table, all right? So I start in pretty much everybody's in a temporal support, which is just about above the ear, okay? I start them in a neutral position in their legs, and I start them in the neutral cervical curve, and I have them just relaxed. I try to get their shoulder up underneath them, okay? And then I just start going nice and easy, all right? All right. The final stretch comes with my piezoform, all right? Now, there's 14 TPs down there, C0 down the C to T1, and there's 6 spinuses and blah, 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 blah. At the end of the day, there is probably a 5x3 square, okay, that lives here, all right, somewhere in this zone, all right, that you get to work in. All right, and everybody's got the same spots. It's my vagus nerve theory, okay, that everybody's got a vagus nerve, and you saw in anatomy class and dissection, everybody's got it in the same place. Everybody's got the same motion. Everybody's got the same facets. Everybody's got the same disc angles. Everybody's got the same anatomy. And everybody's jammed up in all the same places, only everybody's jammed up more in different places. C1, C5, C7, TPs this way, that way, sagittal motion, TP motion, all these kind of things. And the more you touch people and get in there and start playing the piano and moving stuff around, you'll start feeling these normal motions, okay? And I'm going to teach this at the next conference more and more and more, is the pattern at which I work, okay? And we're going to talk about that right at the end if we have time. Okay, so moving along is doctor connectivity, is the doctor needs to connect to himself. It is so important. I spend 15, 20 minutes, a half an hour of me personally getting ready, okay, physically and mentally. I cannot just walk in a room and adjust somebody, okay, because if you're a piece of concrete, you can't go through concrete. You need to be loose and relaxed and your mind in the right place, okay? It's an inferior hand contact, it's a piezoform contact, and the idea is to connect, to stretch, and to release, okay? And it goes through processes like this, okay, as we step into it with our mass, okay? It's all about the mass. It is like a car. You don't push a car with your arms. You lean into it and drive your mass into it, all right? And what happens is we step into it with our mass, and we step into it with a foot plant, okay? So we use our superior foot goes forward, and our inferior foot goes backward, and we use our inferior foot. So our inferior foot is back, and it's an inferior hand contact, and what you're going to do is you're going to come I to S on most people. Why? Because grandma always falls down. Gravity compresses people. So most of your contacts are going to be I to S, I to S, I to S. All right? You're going to come in with a pisiform contact. All right? And that's where you touch the patient. I do this for a good minute and just check in with each patient for a minute before I even start going into it. I get my rhythm. I feel what's going on. I get connected to them. And all of a sudden, I start feeling where there's some tension, and I start latching on, and I start leaning in. And I feel my pisiform start retracting. And once the pisiform retracts, that's where I initiate that push-pull. So when I feel, as I lean in, that my pisiform is pushing back a little bit, guess what I have to do? I have to push-pull then. And that's when I release with my, I lean in further, I go through my push-pull, and at the bottom, at the very bottom of this thing at max tension, that's where you release your wrist. Okay? And there's basically three things that I do is I bend my wrist, I twist it, or I roll the head. Okay? And that's what I do is I create motion and tension and drive through it. And I just overcome tension, 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 tension through the whole neck, which is the cervical hub, and it's the insertion for the whole body. Because all roads lead up to the neck. And all roads lead to everything. The thing why we use the neck and why we only use the pelvis is because the neck has a three-dimensionality to it. So we can get all three dimension through all three planes of motion there. Well, you can't do that in the pelvis. Can't do it anywhere else. So we get the end game. It's kind of like the steering wheel, you know? It's forward, backward, and, you know, right and left. Okay. So we're going to step into a little bit of some bigger concepts, some S-test concepts. I gave you some stuff there. I highly suggest that you understand where the pisiform retracts and where the wrist lever is engaged, and you'll step in and make that great contact, okay? And then and this is one of the things that you want to do is I love to not use my eyes. I don't like to look at what I'm doing because if you look at what you're doing, you diminish your feel. So your eyes are probably your biggest sense when they're open, and which means they impede everything else. So if you close your eyes or you look away and just focus on your pisiform, you will feel yourself with a much better contact. And I suggest that you slow down and hone that skill, okay? Because the more you get, the more you get, okay? So let's talk about C5, C7, C5, C1. C5, C7 is the insertion for everything down low. So if you've got a foundation that's off and it's tilting, would you move the roof? You would not. You would move the foundation. So you got to be able to have access to it. So C5, C7 are the big insertions for the lower part, or basically spring 1. And C5 to C1, which is here, is the insertions for the upper stuff. So I work a lot in this lower area all day long. And when I want to work stuff in the neck, I work stuff up here much more. Okay? C5 is the bridge between the upper and the lower, and it's that secondary attachment. So C5, and that's why we see C5 have so much trouble, it's that middle of that arc, and it gets beaten by, you know, it's the secondary cleat or secondary anchor in the whole body that holds the insertion, so that when the shoulder is failing, C5 picks it up. When the head and neck are failing and really bending, it uses C5 as a secondary foundation. So it's a foundation and a secondary anchor for the whole body, and that's why we see it get chewed up. All right, but it's also the place to restore motion. So at the end, when I'm done, I drive through this and create three-dimensional motion right into C5, into that spinous. S to I to S, straight on in, and create full three-dimensional motion. And you can push into that, and the more flexibility, you'll start feeling the whole body break loose. So I had a young kid that started in the office last Thursday, and he has seizures every day. His frontal lobe is not completely developed. He's about I'd say somewhere between an 8-year-old and a 12-year-old mentality. He's 24. He's like a freaking bulldog, though, muscular. Okay, he's about 5'7", strong as can be. Scoliosis, big, huge curves. He was referred to by scoliosis doc. He can't even lift his head. He's so much anterior translation. So I adjusted him, and I felt his whole body release. The whole energy let out of it, and he had full three-dimensional motion again. It doesn't mean I took his curves out. I just restored the three-dimensional motion within that structure. And I said to his mom and his dad, they were there, and I said, his life is going to change. I felt it change. I felt the energy release that. Okay? I could have that experience all the time. And I called her the next day, and she said he didn't have a seizure. He has a seizure every night. It's 100%. Seizures all night long. He didn't have any seizure. He slept so hard he peed in the bed. And I told her that, I'm an energy guy. So I said, your son came into this world with a big energy and a small suit. And I said, that suit is all jammed up, and my job is to expand that suit for him. And I did a lot of that today. And that's why he slept, because his energy was at peace finally. Okay, and he hasn't had a seizure since last Thursday, which is a week now. So we'll see what happens. He told his mom when he woke up in the morning, his mom said, how you doing? He says, I'm on turbo today. I'm on turbo. Okay, that's what we do with this by restoring motion. That's what we do when you have a sense, when you get beyond the postural listing and you understand it, you see what has to happen, and you get in there and you start breaking this stuff away and restoring the human body back the way that God gave us, man. That is what we get to do in this technique. Okay, so I want to talk to you a little bit about some head bending, and I want just some of the big people to see that have been around for a while to see this. Is this kind of the motion that I've been going in at? And I may just do a class on this next time because it gets involved. But this is a neutral position. And what I found is there's basically three layers to the body. There's just the fascial layer, which is the muscle system that's trying to hold everything up. And you just kind of have to chip through that. And then the second part of it is the bony structure. You start getting a little bit of motion through some of the muscles after you're chipping it away, a little bit of motion. And all of a sudden you start being able to feel the TPs and the spinuses. And you start bending them three-dimensionally. And you go in, you bend those, bend. It's like a three-dimensional joystick. And then once you go beyond that, then you get into like the dural, it's like the liquid layer where you're creating three-dimensional motion. And you're driving through. And that's when I start bending the head here, lifting it up and really bending it down and creating tension in big circles this way and coming around and moving the body. Okay, so we'll talk more about that next week, but I wanted to talk a little bit about that because there are three head positions, which is neutral, lifting the head up and lifting the head down. Okay. Listen, I'm telling you, I know that to some of you, you would go, man, this is a lot. It's not a lot. It's a complete system that is very congruent. There's no like holes in it. Okay, so we can have a conversation about the postural listing all the way up to how to create tension in this picture and why I need to do it and bend the head down because there's posterior rotation. Why? Because there's anterior rotations. Okay, why? Because the curves are in this one with the head down, that person is collapsing and they have a big anterior translation and they have a hyperlordosis. And I need to lift those curves, not increase those curves. And this one, in the middle one, somebody is hyperlordotic and I'm going to go right through C5 and I'm going to bring their head back and I'm going to restore that sagittal curve so that I can give them bounce. Okay, that's the kind of conversations that I want to be able to have with you guys. Okay, so that being said, okay, we release it, and guess what happens? Something happens. Nothing happens. It gets worse. It gets better. Okay? I like when it gets worse because I like to learn what not to do because it's only what you learn from what not to do that you learn from what to do. You could adjust somebody 3 times, 3 different ways and get the same result, but one of them is stable. Okay? So one of them is more stable, and that's what we want to try to find. So we need to be able to watch the behavior of what we do on our adjustment. And does it open, which means does the rotation open? Does it collapse, meaning what happens when we collapse something? That means we went through their good tension. The stuff that was holding them up, that the nervous system was trying to hold them up, we just knocked over. Is that a good thing? No, that's not a good thing. So we need to understand that better. That's my focus right now. Understanding good tension. Okay, what happens if I push on the right side, and it increases the weight? What happens if it goes away? Okay, what happens if it only goes halfway? These are things that we want to understand. Part spring, part building, weaknesses, strengths, health, damage, okay, and the process for each patient, and the process for us. Okay, so we're going to go through those cases again, and then we're going to wrap it up. We'll be done in about 10 minutes, so hang tight. You guys are good, man. I appreciate you. Is there other? I know this is a lot. It feels like a lot for me, and I know that I'm just looking through it. Most of you have been on here, so you know what's going on, which I'm glad. Happy to see you. Okay, but let's just look at this. Look at this configuration. Okay, this person now is all rights, 19 pounds on the right, 10 in twist in the shoulder. You know that shoulder neck. Look at the neck, how it's bowing. You see how it's trying to hold on to the left. You see it. You see it wanting to do that. You see that. You see it down in the lower lumbars in L3, 2, 1. Do you see how right in here? Hold on. Right here. How that musculature is trying to hold this over, because look how this is falling over. This is trying to hold it up. You see how it bends back? You think that person's going to have some pain here? They're going to tell you, man, oh man, my ribs are killing me here. Look at all that muscle. And you're going to go, oh, man, I'm just going to freaking get up on this right side. I'm just going to bust that thing over to the right and blow it out. Well, you wouldn't. You go out. There's good tension here. You don't want to do that. But there is also bad tension here, my friends. Okay, look how this curves. Okay, there's short tension here. You have to be able to release it. Okay, you have to release the short tension that's here. There's short tension in the front on the right side, right anterior. You have to get in on that right side. Okay, but there's also stuff on the left. All right. So you can't just look at this and go, oh man, that person's already leaning right side. Why? If I got them on the left, I'm just going to blow them over. No, you let innate intelligence decide that. Okay? So when I released this person, this is what happened. Now, what would you do? It went from right 19, A10, A8, left side, and it went kabang, and it flew from right to left. Left side up, it went to a left 3, A2, P2, right. What would you do here?
Leave them alone.
Did it open? Leave it alone. It opened. Look at the rotation came down. Okay, so it's a little counter twisted. I don't care. I'll leave that there all day long. Okay, it's at left 3. It's integrated. Okay. By the way, I've never seen that happen before. It may happen, but not a left. It may come up to left 2, but that spine may be sitting still right and stuff. And I don't care about that. I want to see it open. And here's my deal, guys. Is once I open it and I open it and I open it, I let innate intelligence integrate it. I let innate intelligence, once it's free, it does the job. I stop pushing bones. I start figuring out how to release things the best, and that's my purpose. And that's what I'm going to do forever, as long as I'm doing chiropractic. Is how can I help this person the best? And it starts with that postural listening over and over and over. And the more you understand it, you can't understand it well enough. And you can't understand well enough that where to touch it and how to feel it, and when you release it, what's happening. Okay, so I released this person on the left, and that's what I did. So the actual listing is a left. Let's move on. Okay, this one right here is I released it on. This is after I did after I released the right side. This is my listing. I released it on the right side. Why? Because I have my first spring is a left to right. Okay, so the right is on the top, left is on the bottom platform. Okay, is the pelvis here, and they're non-coplanar. I'm going to release it on the right, and I have then a left release. So after the right, that's what happened. What should I do? Nothing. Okay, I love the way that looks. It looks great. So I'm not going to go do the left side. So the way that I would write that, so to know that in my notes, is I would write this. I would write. Let me see if I can get. I'd go R, X, L. That means I did the right, I didn't do the left. Fair enough? Simple. Okay, moving right along. Okay, case 3. All right. This lady's a chiropractor. She's had neck surgery. Okay. So hopefully she had the neck surgery before she saw chiropractic people. All right. So this is a left, and when I released it, what happened? What happened? Look at the just look at the whole thing. Look at what happened to the rotation first. Did it open?
Yes.
Yeah, it opened, and it opened enough. I mean, it wasn't really closed up anyway, was it?
It's counter rotated.
That's right. It's a counter rotated, right? But that listing is telling me that that person with all those rights and 14 pounds on the right, they're holding that up pretty decently. You know, they're not collapsing. So this person's holding a 14-pound suitcase all on the right, and they're holding it up pretty decently, and they're counter rotating, yeah, but it's small. Okay. So what happened to it? So it opened. Is that good? That's great. Does it need the left side? Yes, because that's the one that opened it. Okay, but what did the spring do? Did the spring bounce up? It went from 14 to 9. Is that enough? No, it's not enough. So it's going in the right direction. So I'm going to follow an 8, and it has some building properties to it, and it also has some spring properties. The spring opened it, and the spring bounced it up from a 14 to a 9. So I'm going to turn them over, and I'm going to help them up. What happens if I help them up and it went to a right 20, and it collapsed?
Go back to left.
Yeah, I should have left it alone and probably rested the patient and allowed it to come up on its own. And then I know that for next time. And I go, okay, you know what? It came to 9 last time. It's doing the same thing today. Why don't you go rest and let's see if it goes the rest of the way. Fair? That's how you learn. But I definitely learned when I turned the person over that they didn't like that. Today, that doesn't mean forever. I love touching people and messing up. It's the only way I learn. Okay, so today, if I adjusted this person and I got this left release and the rotations came out, which is what's right here, boom, that means I sprung the spring out. I have the spring, it's been compressed, it's twisted, okay, because that's what twist represents, is compression, okay? And you got to get the house up before you can move it over, okay? So it's open. It just didn't move to center all its way, and because I pushed it on the left, which way is it going? It's going right to left. So it says, hey, Russ, turn it over, go follow innate intelligence. And that's what I do. Flip them over on the right, give them C7 to C5, pop, 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 get that weight out of there around the TPs. And I don't want to talk to you like a mechanic because that's not the way I do it, but that is some insight that you want to look there and make sure you clear that C7 to C5. All right. You want to make sure that you get in front, up all the way up in front of the neck and down the clavicle, because everybody also falls forward. Okay? And that's what I do. I flip it over, and I see how it goes. And hopefully it went to left 2, right 1, right 3, or it just went a little bit better. Great. And if it didn't, which probably won't be the case, okay? It won't fall back down. You know. Okay. Case 4. All right, so just take a look at it. Feel that. Notice how you have a left pelvis, a left fixed point, a left shoulder, a left neck, and you have right weight. Okay? Can you, if you just stood out and tilted yourself to the left and everything to the left except your head, just leave your head to the left too, because it doesn't matter at this point. How do you get right weight is by pushing your pelvis over to the right. And that's because our legs are failing down here. That's what's going on with these legs. They're doing this, and this whole thing is shifting out that way. You see that? Everything goes left, okay, but it doesn't have left weight. It's got weight in the right frontal plane, and that's because this thing isn't just doing this and this. This whole thing is swinging out this way, and these legs are doing this now. That's this person's in trouble. This is a year care plan. Easy. That's good, by the way, guys. Okay? Because otherwise you can't help them. Okay? All right, so I released the person, and what did we do? We went right side up. Hey, that looks good. I like doing right side up because look at this, man. You got right 19, you got a left pelvis and a left spine. Let's see if we can get that weight off that right side, okay, and get that thing to pop out of there. Okay, it's swinging out. Okay, that's not the way I would see this thing to if this thing is, well, I don't want to get into that. Okay, so I go with the algorithm, and that's what happens. Is that good? Did it open?
Yes, it opened.
It opened. Okay. So is 22 pounds on the left good?
Better than 19 right.
Better than 19 right, but are you finished, Brad?
No.
No, so I would turn this person over, okay, and I now know that the right side opens them up. Okay, the right side has opened them. Here's my rotation. This is open to 4 and 2, 3 and 2, 0 to 3 is normal. So we're close. We're moving in the right direction. So it's lifting. I see the rotation is changing. That's what you got to look at on the post. Okay, is what's the rotation doing? I also see that the weight went right to left, and I released it right to left. It went this way. Boom, 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 boom. And guess what? This whole sucker now is sitting out here like that. This whole body is sitting out there. So you know what I'm going to do? I'm going to turn her over, and I'm going to help her try to get it up on center. So what's my actual listing? It says right, and this is where I delineate that, left. So I use an X when I don't do something that's in the algorithm, and when I have to add something, I add the dash. And that's telling me basically that person didn't just go flying over to the left and pop up. Why? Because the spring's not working. So I had to turn them over and help them up. That's all. Next. Okay. We're in the home stretch. Last one. Actually, I won't even do this one. So these are the listings and the nomenclatures, okay? This stuff on the side. Somebody could be a right. It doesn't mean I adjust them twice on the right. Okay? It just means that the bottom spring and the top spring are asking for the same release. Okay? If I adjusted somebody on the right, all right, and it came back at me or it collapsed or something like that, I would turn them over. If it cleared, fantastic. If I adjusted them on the right and it fell over further on the left, I'd probably flip them over and I'd adjust them on the left. And that's when I would come in and I'd write that kind of thing. So this is what I have: a right, a right, left, and this is what I write in my notes. Okay? Right, left, right, RXL. That means the algorithm said do RL, but I didn't do the left side because the right side cleared them. It opened them and they came to center. Or it just opened them and I wanted to leave them there. You got to open them. What does this one say? This one says, I did R, it looked good, but I said, I think I better do L. And I do L, and guess what happened? It didn't like that. So I had to go back and do the R. This one says, just do L. Wasn't enough, I had to help them and flip them over. Okay? All right. So, last slide. First, thank you for hanging in there. I know that's long. I know that's a lot of information. And hopefully you guys come back next time. But so I see what I'm doing now in a sense that we have got this living, breathing model in chiropractic. And I can look at somebody's misalignment. I can look at them visually in front of me. I have a measuring system, and I can look at them and I can talk to them about their structural damage, their neurologic damage, their energetic system, biomechanically correct, things that are changing, things that I do over a few visits, and I go, you know what? This guy is going to be the troublemaker, and this is where the work needs to be done. I can identify that. I can identify the things that are changing. To me, it's a fascinating day for chiropractic to be able to do that. Okay, so to be able to look at each person and try to understand them. Okay, so I came into the profession saying to my mentor in upper cervical work, just tell me how to fix them. And I've come to a place where we don't fix anybody. We support the damaged structure by trying to understand it as well as possible. And that's where we stand today. And that's what I've been doing for the past 10 years. And a lot of you on this call have been with me in that trip. Okay. So I'm going to close by making one comment and then asking some questions. So I am posting on the Facebook Doctors Forum. And Facebook is not being friendly right now to the forum. And I'll tell you why, because I put a video up and it has 70 views. And then Facebook says that I have 6 people look at it. I go ahead and I go on Facebook and I can't even see the post that I just put up 10 minutes ago. So I'm going to ask you to please check into the Facebook members site and to like some of the posts, please, if you like them, not just look at them, so that we can actually change the algorithm for the page so that you can actually see what I'm posting. Because more people that like it, it'll start posting as an algorithm for people that are not seeing it. Okay? So if you can do that when you're done and do that through the week, but I'm going to start posting up some cases. I put up a couple cases, I think today and yesterday already, that walk through these kind of concepts that we were talking about to start looking at it and feeling it and seeing it more with more depth. Okay? All right. Any questions on something that you? I know, Brad, you had a question before and we never got to it, and I'm sorry about that. But is there anything that anybody would like to ask? Okay. All right, very nice. All right, night-night. I'll get this up, and I'm always willing to chat, and I look forward to hearing from you. And please go on the Facebook site and help me out. All right, have a beautiful night.